Good evening. It's nice to have you all with us again.
Yes, welcome everybody on really what was a wonderful fall afternoon after the incredibly rainy, gusty, crazy weather of yesterday. So the three of us have been kind of angling against the sunshine beating down through our windows, but it looks like the sun is going down now and it should be easier.
Well, I'm especially excited to have Suzanne Crawford-O'Brien with us this evening, and she's going to be speaking with us on epidemics in Indian country, COVID-19, and colonialism. And this is an area that is of interest to my own teaching. So I'm really grateful for Suzanne for being here. And Suzanne is a professor of religion and chair of the Native and Indigenous Studies program. And we're really looking forward to the information and the analysis that she will be sharing with us this evening. So we will turn things over to Suzanne.
Thank you.
Thank you guys. And thank you all for being here. I have to start by giving a shout out to my mom and dad who are taking this course and signed up. So go Jeannie and Tim, and hi Mom. This is it makes it a very special treat for me, and I love that they're being involved. Last week, Dr. Palermo invited you all to make a note in the chat about the tribal people whose land you are on, and I thought that was a really beautiful way to bring that in. And I wonder if any of you maybe didn't know and looked it up over the course of the week. If so, there we go. Thank you, Juliana. Dana, Ina, good. Did anybody else look it up over the course of the week? Maybe you weren't sure, maybe you wanted to know a little more. Squamish, Lower Skagit, Snohomish, nice. Great. So we've got two people in Dena'ina territory, nice. Yeah, Australia. Squamish Sioux, yay, awesome. Puyallup. Great. All right, so it's so important to do those land acknowledgements, right? Because it reminds us of where we are and whose land we're on, and that's so important. Spokane. One of the things about land acknowledgements that is also kind of a challenge is to think about how we can take Muckleshoot, woohoo! How we can take the land acknowledgement a step further. So two Native philosophers that I love and that I love reading are Robin Wall Kimmerer, who's Potawatomi, and Charles Atleo, who's Nuu-chah-nulth from Vancouver Island. And they both write about how important it is to really see and pay attention and recognize the personhood of plant and animal people, but also of other human beings, to recognize that. And when you recognize the personhood of someone else, it changes, and not just seeing them as an object, right? Which we do all the time. We objectify people around us just on a constant basis. But when we go from seeing the other person as an object to a real person, a full person, it changes the way we think and feel to them. And it ought to inspire respect, right? That then we treat them with respect. It also ought to inspire us to see what they give us. And what we receive from them, and to feel a sense of gratitude for the gifts that they give, right? And gratitude then should inspire reciprocity or a desire to give back. So I wonder, just to take that land acknowledgement one little step farther, what are some ways that how might we give back to the tribal communities on whose land we live? So what do you think, again, in the chat, what do you think are some things, what are ways that we can, whether you're native or non-native, whether you're native to that area or maybe you're native from somewhere else, how do you honor the people on whose land you are? What are some ways you can do that? What do you think? Ask questions, yes. Learn more. Mm-hmm. Respect, yes. Respect the communities, respect the land. Any other thoughts? Listen. Partnership for education, cleaning up land and waterways, repatriating land, yes, taking care of the environment. Mm-hmm. Good. So there are lots of ways in terms of how we live on the land that we can live respectfully and with care. I want you to keep thinking about this question as we go on with the lecture, because I think I'll offer a couple other suggestions as well of some ways we can live as neighbors and allies. So I'll go ahead and start. So as the abstract for this lecture started with this very Instagram post. So a recent Instagram post by the Quileute that was posted said the Quileute Reservation at La Push, Washington is closed to all visitors. Once it is deemed safe to reopen again, we welcome all visitors back to our lands, except the Cullens. Now, if you have read the Twilight series, like I have to admit I have, you know what that joke is referring to. The Cullens are the vampires. Yeah. Ooh, and I apologize if you hear my dog barking in the background. This is the joy of Zoom meetings. You get the whole thing. So this statement is comedic, but it's also really telling, right? Because this is reflecting a decision being made across North America by tribal communities who are having to make really tough decisions to protect their communities against COVID-19. So in any conversation about Native communities, first thing I always want to say is, oh my gosh, there's so much diversity here, and any generalizations I make have to always be taken with sort of that acknowledgement that these are generalizations. And I'm going to try and observe those things that are most applicable broadly, but there's always going to be exceptions, right? There's 574 federally recognized tribes in the United States. This is incredible cultural, linguistic, geographic diversity, just all over the board, right? A great deal of difference. And the impact on those communities has varied widely, just as widely as those communities are themselves. So some have been really hard hit, others have seen almost no impact at all. But they're all wrestling with the question of how they can best protect their communities, how do they keep them safe? And what's really striking, one thing that stands out to me almost immediately, is that across the board, tribal nations responded fast, they responded incredibly strongly, and with really strict protocols that were almost always much stricter than the communities, the counties, the states around them. So they moved very quickly. So by way of example, the Makah Nation, who is just north of the Quileute on the Washington coast, they closed their borders in early March, right away. As recently as last Wednesday, they posted on their website, so this is just a couple days ago, while the state and county have moved into phases of reopening, the reservation remains closed to all visitors until further notice. Please anticipate the reservation being closed throughout the remainder of the year, with a reopening not planned at this time. So they're taking this extremely seriously, and we find examples of this elsewhere across the nation. So in California, tribes like the Hoopa Valley and the Yurok closed the reservation to non-residents. Travelers still could go through on the highway, but they couldn't stop. Tribal residents were ordered to shelter in place. In South Dakota, as many of you probably have heard, the Cheyenne River and Oglala Sioux tribes closed their reservations as well, and they set up checkpoints on the roads going in and out of those reservations. And this sparked some pretty considerable conflict with state officials who didn't feel they had the authority to do that. There were threats of reprisal. And this was particularly contentious during the Sturgis motorcycle rally that took place in August, where folks wanted to cross through those highways and the tribe said, heck no. Unable to block their reservation, the Navajo Nation responded by closing. They couldn't close the roads, or they didn't feel they could, but they closed all tourist attractions. They issued statements asking visitors to stay home, said, please don't come. When everything's closed, we don't want you. And those decisions are striking because they were so fast and they were so emphatic, right? But they're also really striking because these are the heart of most tribal economies, right? They were shutting down their economy to protect their people in very serious ways. Those casinos, especially those tourist attractions, they fund their schools, they fund their health centers, they keep their public services afloat. This is some of their primary income. And so for them to move quickly without hesitation, it says a lot. So for me, the big question that I bring to this lecture is why, right? So why did they make that decision when a lot of county, state, and federal government decision makers couldn't make that decision, or hesitated a great deal, or had a much harder time making that decision? Why were they doing that? And these are all sovereign nations who, they're making these decisions independently of each other. So it's very interesting that you see this common movement across the nation, across all these different Native nations. So to get at that, I wanted to look at this from 4 different perspectives, to kind of think about 4 different issues here. So one is epidemiology, the second is history, And then I also want to think about spirituality and ethics. So what are the spiritual ideas or sensibilities and ethical sensibilities prompting these decisions? So yeah, a little note here. I'm an interdisciplinary scholar, so I tend to approach everything from multiple angles at once. I want to try and get the whole picture and look at it from all the different angles. And so it does mean that I don't often get to go really, really, really deep into one very particular idea or a very particular method. I tend to draw on multiple methods at once because I really want to understand this kind of big picture. So I think last week you saw an excellent example of a really close reading of a particular text that was just done so beautifully. And we won't get to do very much of that today. It'll be a much sort of broader picture. But the first thing I want to think about is epidemiology. We can move on to that. So epidemiology, when we think about that, it's this analysis of the patterns and determinants of health and diseases in particular populations. So what are the patterns of disease? And what is determining how those patterns move? So what are likelihood, things that are likely to happen, and what kind of things might set up a community to make them particularly vulnerable? So I wonder again in the chat, what are the kinds of things that come to mind when you think about social determinants of health? So what kinds of things do you think might determine a community's ability to cope with a disease like COVID? Or what might make a community more vulnerable? What do you think? If you want access to healthcare, yeah. Location, socioeconomic status, the age, elderly, children, yes. Wealth, income gaps, economics, nutrition, yes. Yeah. Yes. Yeah, so these social cohesion, right? Like how tight is your community? Exposure to the virus, yes. Are you able to stay within, or are you exposed? Their agency in local politics, yeah. How much voice do you have to be able to determine your own fate through your local government? Systematic issues, yeah. Systemic inequalities, things like that. Great, yes. Space capacity, yes, yeah. So is there room in hospitals? Is there space? Are they able to care for people? Great. All right, I can just go home. I can shut this down. You got it. We're good. I'll just see you. No, I'm just kidding. I will keep talking because that's what I like to do. But you guys have it, yes. So when we think about these kinds of things, what do they look like in Native communities? You're right on. These are the kind of issues we need to think about. So one of the reasons those tribes moved so fast and acted so quickly and so with such determination was because they knew they were particularly vulnerable. They saw this coming and they said, we are at risk, and they knew this right away. So this is where those social determinants of health come in. What are those conditions? Well, one of them, just as you said, is poverty. So Native communities are again, there's great diversity here. There are many middle class and very comfortable Native people, but there's also higher statistical rates of poverty in these communities, especially in reservation communities. So the number here on the screen, 57,600, that's the median income for the US of A general population. In Native communities, it's 39,700. So that's for families that identify as Indigenous. Native communities are also, and families are far less likely to have access to clean running water and sanitation. They're far less likely, more than any other group, to lack access to Wi-Fi or cell service. So these, and think about not having Wi-Fi right now, right? Like this is really fundamental to our lives right now. Native communities are far less likely to have access to that. Access to insurance. Their Native people are twice as likely to not have insurance than the general population of the nation. And that's a complicated issue, and there's a lot of reasons for it I can talk more about, but that is the case. They're also far more likely to have pre-existing conditions. So there's 6 times, tuberculosis, to me, I think of that as a disease from the 19th century. It's very much still an issue in Native communities. They're 6 times more likely to have tuberculosis, 2.5 times more likely to suffer from diabetes. Type 2 diabetes is an epidemic in Indian country that tribal communities are really focused on addressing, but it makes them very vulnerable to higher risk if they should contract COVID. Obesity, kidney and liver and heart disease are also problems within these communities at much higher rates than the general population. Multi-generational households is another piece. So Native communities are far more likely to have big extended families living together. So grandparents, great aunties, great uncles, cousins, nieces and nephews, and the ability to separate or isolate if someone becomes sick, living often in a lot of folks in a smaller home, so they're sharing rooms, and just that higher rate of transmission because of that too. So tribal communities, as I shared this comes from the American Public Media resource that I shared with you all. This is where these stats are coming from if you want to look at them more. But these were just updated about a month ago. So they're September 15th, so they'll be re-updating them again pretty soon. But I think we'll see pretty similar kinds of trends. So as you can see here, nationally, the Indigenous communities have a rate of 81.9 deaths per 100,000 compared to 46.6 for white folks. Pacific Islanders also have a high rate, as do other communities, right? So the graph on this screen right here, if you can't see, that's the state of Washington. So nationally, Native people are almost twice as likely to perish. But when it gets even more intense when you look at communities that have a higher population of Native people. So in Washington state, Indigenous people are more likely to, Indigenous folks at 63.9 per 100,000 compared to 23.8 for white folks. Pacific Islanders is the purple band. They have the second highest rate of fatalities in our state. In Alaska, the transmission rate has been pretty low, but it's still the case that Native Alaskans are far more likely to be vulnerable and potentially die from the disease than their white neighbors. South Dakota, 56.1 compared to 15.9. So really dramatic disparities. Again, in Minnesota, they've had a pretty high rates of infection in Minnesota, 57.4 for Indigenous folks, white folks 32.2. New Mexico and Arizona have had the highest rates that have been the most distressing to see this disparity. So that chart right here is New Mexico. You can see so Arizona, 203 deaths per 100,000 compared to 57.2. In New Mexico, 231.6. So this enormous disparity between Indigenous folks. This gets even more intense when it then adjusted for age. And this is because Native communities are much younger. They have much more people that are young than white communities. So once you adjust for that difference in age disparities, the differences become even greater. So you can see nationally it goes from 81.9 to 124.7 to 38.4. In South Dakota, 136.6 to 13.4. In Arizona, 334.9 to 25.3. So statistically, and as I share with all my students on a regular basis, numbers are not my strong suit. I'm a humanities person, but even I can tell these are pretty meaningful numbers, right? This tells you a lot about this dramatic disparity between these communities. And again, it has a great deal to do with poverty, with the nature of the communities and the kinds of resources they have. Okay. So this was just released from the Navajo Nation on just 2 days ago. So when thinking about the differences amongst communities and how they've been affected, the Navajo Nation has reported the most cases by far. So you've probably read about them in the news. As of last week, they had 10,728 cases, of whom, as you see here, 7,343 have recovered. They've had a total of 571 people who have passed away. And their infection rate is about 2 to 3 times the national average, depending on when you're looking at it. The highest infection rates have been to particular communities again. So the Navajo had the highest numbers. The highest per capita impacts have been smaller communities. The Mississippi Band of Choctaw, 10% of their community has contracted the disease. They've lost nearly 100 people out of a very small community, so it's been deeply impactful. The Pueblo of Zia, White Mountain Apache, Pueblo San Felipe, Kiowa Pueblo, Winnebago Tribe of Nebraska, Colorado Indian Tribe, these have all been hit really strongly. And again, that kind of these close-knit communities where folks are living very closely together, and it swept through them so so quickly that even with their precautions, you know, that it's still been so hard to close it down. The Yakima tribe have been hit the hardest in Washington. And as the Choctaw Health Center director, Mary Harrison, was quoted, as she points out here, when we talk about these numbers, they're not just numbers. As she says, we aren't losing family members or an aunt or uncle, we're losing parts of our culture. We've lost artists, we've lost dressmakers, we've lost artists, elders who were very fluid in our language. So when you think about an individual we've lost, these are important people in our community. Yeah. So that epidemiology there's so much more we could say about it, right? But we know that these communities, there are all sorts of risk factors that elevate their vulnerability, and they've been very right? This could have been much worse, as bad as it is. It could have been even worse if they hadn't responded. So another part of their response that I want to uplift here is the historical context. So again, in the chat, why don't you tell me, what do you think might have been motivating their decisions based on what you might know of Native American history? So what might be inspiring them to make the calls they did? Smallpox, 1918 flu epidemic, yes. Yes. Mm-hmm. Yeah. So we have a history with epidemic disease, right? Very much so. Yep. So we have 500 years of genocide. Yeah, there's a lot of going on there. So we have a historical context that these communities are very aware of, and I think the dominant American society is generally guilty of a whole lot of historical amnesia, but other communities remember their history much better, and Native communities most definitely do. So there's a very vivid and visceral memory of epidemic disease, the impact it had in decimating communities. There's also a memory of the federal government's efforts to suppress traditional healing practices, which went on for a long time. Also historical access to care, and also strong memories of ethical abuses within the medical system that make them very reluctant to not have a hand in managing their own care, right? So that move to say, we're gonna be in charge of what's gonna happen to us, we're gonna draw our boundaries, and we're gonna take care of ourselves, that's really inspired by their history. So as some of you have mentioned there, right? Native communities remember this epidemiological history. So the numbers really vary widely depending on who you're talking to, what the original sort of population was of North America prior to colonialism, but somewhere between 5 and 18 million people, right? That's a big window, 5 to 18 million people, indigenous people lived in North America prior to colonialism. But regardless, we know that by 1800, that number had dropped to 600,000. From 5 to 18 million to 600,000 by 1800, and that's because of introduced contagion. And we know that by 1890, it was as low as 250,000. So from 5 to 18 million to 250,000. The vast majority of those deaths were caused by non-native introduced diseases. So smallpox, plague, cholera, influenza, malaria, diphtheria, tuberculosis, syphilis, gonorrhea, these things that were brought to these communities. And in some instances, most of the time, this was the wave of disease transporting itself, right? But it was also the case that sometimes illness was used as a form of germ warfare to eliminate communities and to suppress dissent. So some of you may know this story already. In 1763, thousands upon thousands of Haudenosaunee people in the Northeast perished after blankets infected with smallpox were distributed among Odawa, Ojibwe, Lenape, and Shawnee people. And it was done at the express instruction of Lord Jeffrey Amherst, who instructed his field commanders to remove infected smallpox blankets from British soldiers and distribute them to Native communities as gifts. Another notorious example of this was in 1832 when Andrew Jackson's administration intentionally relocated a Choctaw community into the middle of a cholera epidemic. This was overruled. He was overruling protests from white physicians and white humanitarian groups who were begging him not to do this, and the Choctaw themselves who knew where they were being sent. He did it anyway. In the Pacific Northwest, we have an example of the use of the fear of illness to subdue communities. So in a really striking example, this was at Fort Astor. Duncan McDougall, so in the early days, in the early 1800s, Duncan McDougall met with Chinook tribal leaders, and he told them, "The white men among you are few in number, it is true, but we are mighty in medicine." And he held up a vial for all to see and said, "In this bottle I hold smallpox all corked up. I have but to draw the cork to let loose the pestilence and sweep man, woman, and child from the face of the earth." The folks he was speaking with had endured 3 subsequent waves of smallpox prior to this, starting in 1790, again in around 1805, and again in just a few years after that. They had seen their communities decimated. Most of them probably bore scars from the disease themselves. Entire villages were wiped out by smallpox. So for him to stand up and make this claim, which was completely believable, it reduced them all to subservience. They did not dare resist, and they certainly worked for the men at Fort Astor and did not bargain or make any kind of resistance to the sort of deals they were offered, right? Because they lived in fear because of this kind of narrative. So I grew up in Portland. I went berry picking on Savi's Island many, many summers. So reading about this history and learning that there had been a Chinook community on Savi's Island where every single person died because of smallpox. These illnesses had real impacts on real communities in utterly devastating ways. And in the interest of time, I won't go too much into it, but in Indigenous disease etiology, so etiology is the understanding of where disease comes from, what makes you sick, like what causes it. In Chinook and Coast Salish disease etiology, traditionally, there are these different understandings of where disease comes from. So you've got natural disease, which is like you get an injury or a problem with childbirth or trauma or an accident, or you break your leg, you get a rash from a plant you shouldn't have touched, right? Those are natural ailments. There's also supernatural ailments, and those come from spiritual causes. So there's a lot of things that cause spiritual ailments. You could offend a spiritual being. There might be some witchcraft going on. There's some kind of relational upset that needs to be fixed. But after colonialism, a third category was added, and that was white people's disease, right? And so white people's disease is those things like smallpox, things like malaria, but it's also things like alcoholism and domestic violence are categorized as white folks' disease because those things were considered to be something new that came as a result of colonialism. So we have this history of epidemics that were decimating and used intentionally as sometimes very conscious intentional tools of colonial control. Even when they weren't, they were certainly seen by Native communities as something brought by by settler colonial society. So another piece of this history that's really important to understand is the history of historical access to care and how that's been brought to Native communities. So when reservations were first established with Native communities around the 1850s, 1860s, they signed treaties with the federal government, right, reserving certain lands and certain rights to themselves. And the government promised certain things in return for them ceding enormous amounts of their land for settlement. And one of the things promised in those treaties was healthcare. Yeah, that they would receive healthcare. They would receive a physician, and they would receive healthcare necessary as was necessary. Now, of course, in the 1850s, healthcare was nothing to write home about. It was not great, right? But it was still something that was promised. And to my knowledge, and I could be wrong, but to my knowledge, Native people who are signatories to those treaties, I think, are the only group in this country, certainly the only ethnic group in this country, that's legally guaranteed healthcare. That the government has a legal obligation to provide healthcare for. I think veterans might be the only other group, maybe. But certainly Indigenous people are distinct in this way. The federal government is obligated legally to provide them healthcare. It never went well, right? For most of and a lot more can be said about this, but for decades, you might have one physician covering thousands of miles of territory or hundreds of miles of territory, having to travel days to even just sort of cover the space they were in. Most people never had access to a physician. Most Native people on reservations for many, many decades never really had access to healthcare. When it did, it was incredibly poorly funded and poorly organized. And tribal communities continued to have the lowest life expectancies, highest infant mortality rates in the nation. So some of this started to change. So in the 20th century, 1934 was a really important era. It was sort of the era that the Indian New Deal was signed. This is the Dawes Act was signed into law. Sorry, not the Dawes Act. This is the Collier Bill. Dawes Act was something else. The Collier Bill. John Collier was sort of the guy who authored and implemented this. And what the Indian New Deal did was it changed the federal government's approach to Native communities. Rather than trying to do away with them, it instituted a level of self-government, and it also tried to reform healthcare to make it a little more culturally appropriate. So there were actually some really, really interesting things that happened, especially on the Navajo reservation, around trying to innovate culturally congruent care, integrating Navajo culture in the 1930s. It's really quite fascinating. It was all kind of forgotten about as government shifted from FDR to the 1950s, which had a much more conservative bent, and instead moved toward limiting tribal government. But in 1955, one important piece of this was that the Indian Health Service, it was really formalized as part of the Department of the Interior. It had actually been managed by an entirely different organization. So it moves into the Department of Interior, 1955. And they create this kind of national network of hospitals and clinics. That's the Indian Health Service, or the IHS. But it's really underfunded, like notoriously underfunded, understaffed, poor, and with staff that generally are not knowledgeable about Native cultures or very respectful of Native cultures. They were also regional. So in order to get to one, you might have to travel a really, really long way. So I remember talking to folks in South Puget Sound, Native communities, who said, yeah, if grandma was sick, you had to go to Quinaults, and it would take you all day to get there. And then you'd wait all day hoping to be seen, and then you might not be seen. And then you have to find some place to stay. And they often said, I heard more than one person say, that's just where you go to die, because you're not going to be well taken care of, and you only go there as a last resort. That's just where you go to die. And I'm sure that was not the universal case, but I certainly heard that said quite a few times. There was a great deal of distrust. Just generations of poor treatment did not lead people to trust the system. I've got way too much, I go way too deep on things. I need to be careful. Okay. I guess an important thing to mention here is that one of the things that really instilled that distrust for a lot of Native women was a history of forced sterilization. So in the 1960s and especially the 1970s, historian Jane Lawrence has estimated and documented that somewhere between 25 and 50% of Native women in the US were sterilized in the IHS. Many, many, many of them were done so under extremely dubious means. So she documented examples where patients were given vague or misleading or wrong information about the procedure. She had quoted folks who had said, they told me my hysterectomy was reversible. Others were coerced into signing forms, the many examples of them threatening forms while they were under sedation, or they were threatened with the loss of their children or their welfare benefits if they didn't sign. Many of them didn't speak English or know what they were signing, so this really dubious moment. And within that decade, Native women's birth rates fell from 3.3 to 1.3, so over that decade. And there are many Native women have written and talked about this really traumatizing moment in our history. By the 1980s, the IHS provided one physician per 1,500 people, okay? So the World Health Organization recommends for developing nations that they aim for a minimal threshold of one physician per 1,000 people for developing nations, okay? Our native communities have one physician per 1,500 people. That has not improved much since the 1980s. On average in the US, for nationally, it's one physician per 373 patients. So a really dramatic difference. So the IHS remains really badly underfunded and understaffed, despite regularly constant pleas to the federal administration. If I can tell you some more numbers that are distressing, they spend about $3,000 a year per patient. That's about a fourth of what the federal government spends on Medicare patients per patient, and about half of what they spend on Medicaid patients. It's about a third of what we spend on inmate care in prisons. So the vacancy rate at IHS hospitals is another thing. Huge vacancy rate for doctors and nurses. When students say to me, how can I support Native communities? I say, go become a teacher, go become a nurse, go become a doctor, and go work in a Native community, because they need people who will go there and who will stay and be part of the community and not just visit for a few months and then take off. So during the pandemic, they remained really underfunded, okay? So lacking the supplies they needed. And that lack of access has remained. Now, the Indian Self-Determination Act, Self-Determination Education Assistance Act, changed things quite a bit because it changed the way tribes could access their care. It enabled them to contract and keep care in-house. So this was kind of a big deal. So a lot of tribal communities were able to say, we're gonna build our own wellness center. Here's the Puyallup Tribal Health Authority. They were one of the first to do this. Immediately after this, almost immediately after the law was passed, they were one of the folks really pushing for it. So they were able to move away from the IHS and build their own clinics and wellness centers and hospitals and fund them themselves. Problem is, they have some funding from the federal government, but they really depend on casino revenue to keep it going. If you've got a casino, that works. If you don't have a casino, that doesn't work. And a lot of tribal communities don't have casinos. So that's a whole lot of background, right? And there's so much more that can be said. But boy, okay, religion professor, let's finally get to religion now that we're almost running out of time. So I want to talk about, there's also religious and ethical concerns here, yeah, that are motivating communities to make these decisions. So we have a history that is really ripe in people's minds. We have knowledge of vulnerability, but we're also really these communities, and I'm not making this up. This is across the board in communities. You hear this language over and over. If at national wellness conferences and workshops, this is the language that comes up. So these kinds of concerns that really motivate them, these core values and spiritual concerns, okay? So religious life has totally been impacted for Native communities, just like for us. You know, churches are online, Indigenous ceremonies are put on hold, tribal journeys, the big intertribal canoe journey in the Northwest, that got canceled this summer. Sun dances are off, stomp dances are off, all the big summer ceremonies canceled, right? So you have small family gatherings, but the big stuff's all canceled. They're doing really creative things online, but as we know, it's just not the same. They're still politically organizing on Zoom and the occasional protest, but really almost everything's gone online. But to think about the original question, right? What's motivating those decisions? I want to consider a few really key values here. So some of those core values that I'm going to argue would see across the nation that are really shared values. So relational reciprocity, having a multi-generational perspective, and a care for elders. These are really, really important things. So the first is this understanding of relational reciprocity, okay? And this is this understanding that health, what it means to be healthy, is dependent on balanced, harmonious relationships. That's the very foundation of what makes for a healthy body, spirit, and mind. Balanced, harmonious relationships, okay? So these are relationships with the natural world, relationships with holy people or spiritual people that live in the natural world or the creator, relationships with your ancestors, and relationships with your human community. When those things are all in place, you are far more likely to be resilient and healthy, yeah? Mentally, spiritually, and physically. So while our culture tends to really uplift individualism and independence as this almighty sign of goodness, right? If you can achieve individuation, you are healthy. In Indigenous cultures, that would more likely be seen as pathological. So a great example of this, Richard Otleo, who I mentioned before, who I am totally such a fan of. He's amazing. He's a hereditary chief of the Nuchalnath. He's also a PhD and a scholar. He's written that in Nuchalnath, the word for kind, like to be a kind person, it isn't just someone who helps other people, it's someone who also will receive help when they need it and will ask for help when they need it. Because being kind is being in relationship and acknowledging that connection and mutual dependency with other people. So in these healing traditions, one of the primary goals is to restore relationships with the natural world, with your ancestors, and all these different ceremonies do this in all these beautiful different ways. Herbalist traditions are doing this because you're not just taking a plant medicine, you're being in relationship with that plant. Ceremonies do that by restoring you with relationship with human and more than human communities. So that this is also an ethical obligation, right? It's foundational to Native North American cultures, and it also helps explain their reaction to COVID, because the care for others is more important than personal convenience, and it really accounts for this sacrifice of personal, again, convenience for the sake of keeping others safe. So Vine Deloria really put this distinction beautifully and concisely about this kind of fundamental difference, what he saw between mainstream American culture and Indigenous communities. And he said, the basic problem is that American society is a rights society, not a responsibilities society. Indigenous cultures, the spiritual teachings are so much about your responsibilities to other people, right? To care for those other people and to look out for them. And that's more important than your personal individual rights. Okay. So, when thinking about COVID, we can kind of see this American mainstream society where you might privilege your rights to not wear a mask, or when you're going to Costco, as taking precedence over your moral obligation to care for other people. Multi-generational perspective is another thing you hear and see a lot around Native healthcare conversations. So this Haudenosaunee or Iroquois teaching about making decisions for 7 generations, you've probably heard of that. That's what plays in here, right? So deliberations also have to be made with 7 generations ahead and 7 generations behind in mind. So you're both thinking of the ancestors and how they are seeing what you're doing, because the ancestors are around and they're watching. They're very much a living part of life. They're present, right? So you want to honor them. You want to make your decisions in a way and live in an honorable way for them. And then you also want to make decisions that are going to have good repercussions for 7 generations down the road. So with that kind of sense, again, it shapes the way you might think about your present moment, because the present moment might be really hard, but if you can assure yourself that you're making decisions that are the best for those 7 generations down the road, and if you're making decisions that will reflect well on those behind you, if you see yourself as being part of a continuum, and there's some really interesting scholarship about this, about mental health in Native communities, and that those folks who are most mentally healthy are aware that they are part of a continuum in time. They know they come from generations behind them, and they're going, and they have a connection with generations to come, and knowing that you're part of that lineage makes a huge difference in how you make decisions, right? So this, in that light, immediate short-term financial pressures are intense, but making that decision to shut everything down because it's the right decision for those multiple generations, it makes sense, right? That greater sense of historical perspective, that greater sense of your location in a historical continuity gives you the ability to make those hard decisions. Okay. Final thing I want to talk about there is this care for elders. And this, I think, is one of the most interesting things. Because Indigenous communities are guided by this reverential care for their elders. And this is one of the things that strikes people, I think, when they hang out with Native communities for the first time. It's so striking because it's so different than mainstream American culture, right? Where, I mean, right? we tend to see aging as a crisis that you have to fight every step of the way. And of course we love those elders in our lives, but our culture rarely accords them the care and the attention they deserve. Yeah. And of course, other traditional societies share this with Native Americans. They're not unique, but it's definitely the case in Native North America. And I've seen people in these communities who are counting the days till they get to be an elder. Like, you look forward to it, right? Because you're going to be so honored and cared for and respected, and you get to eat first, you get to sit first, you get all the best stuff. Like, you are the royalty in the community. So this wonderful image, this was Vernon Black Eyes from Pine Ridge and Sarah Anderson in Omaha. Their daughter, back in March, were out just on the side of the road. They immediately were handing stuff out to elders, and I just thought it was a really cool thing, right? As this kind of expression of, we got to take care of our folks. So this is from a book by Michael McNally, who's an amazing religious studies scholar, and he wrote this book about elders in Anishinaabe cultures. And he says, an aging body alongside a life well lived is testament to the maturation of knowledge and power that these bodies carry, not to mention the authority of experience accrued, tried, tested, and tempered over time. Old age itself marks a kind of religious attainment, and eldership carries a corresponding religious prestige and authority by virtue of mastery of relatedness. So this idea that as you age, you grow in spiritual power and wisdom, right? And this isn't just everybody. As he points out, not everyone gets to be an elder, but people who have aged into wisdom and who have weighed and have led a good life is a sign of spiritual authority. That's the cover of his book. I highly, highly recommend it. He points out that elders pass on power and knowledge toward life to younger generations, and in return, they get respect. So there's always that reciprocity. And respect, he says, is the paradigmatic ethical relation that grounds all other relations in the social, natural, and spiritual realms of Anishinaabe people. So elders have power, they have knowledge, we give them respect and care in return. He says, and this is an important point, if Native people do succeed in distinctly honoring elders, it is emphatically not because they naturally do so. Instead, honoring elders has required hard work, the disciplined labor of moral teaching, and the ritualized decorum that constitute the authority of elders through practices of deference. So the point he makes here is that these ideas, relational reciprocity, multiple generational thinking, care for elders, these aren't like inborn things that Native people are magically just gifted with. They have a culture that works really, really hard to teach these values and inculcates them through, as he says, your practices of deference. So when you give someone your seat, when you give them their food first, when you ask how they're doing, when you make sure you're checking in on them, when they're gifted with the best things and the best gifts, right? All these different things that you build into your life, all these different, this is why Native people often say we don't have a religion, we have a way of life, because these are core values that are just woven throughout everything you do until they become so much second nature, yeah? But I find this really encouraging because having a historical perspective, living in a way that honors relationality with responsibility and care for elders, these are not inborn traits, these are learned things. And what I find encouraging about that is that other people can learn them too, right? So these are things we can all learn and take up and benefit from. Yeah, so to me, that's a hopeful thing, that we can learn and that we can learn how to care for each other and take better care of each other. And I hope that in these moments of unmaking that we find ourselves in right now, we can remake ourselves into a community that is more relational and more respectful and more caring. I want to close by showing you this wonderful 1-minute video that was made by the Portland Area Indian Health Board. Here it is.
Sweats and ceremonies are important to me. My way of life, my family, my community.
However, if I go, I'm not protecting myself and people I love if I spread the coronavirus.
Our leaders and experts say the virus can be spread by someone even if they do not feel sick.
And if this virus spreads to people with health problems like diabetes or kidney disease,
they can really hurt them. COVID-19 is a sad reminder of the ancestors that we have lost to diseases of the past.
Elders told me to adapt by practicing our ways and working up a sweat at home.
exercising my beliefs at home is the best way to keep my family, community, and elders safe.
Now, I'm being prayerful and protecting my people, the knowledge keepers, and our ways of life. Together,
we will
grow stronger.
Go ahead and hit stop share then. 6:51. Covered a lot. Would like to talk for another 2 hours. But happy to take questions through the Q&A button down there on the bottom of your screen, if you would. So do feel free to type in any questions you've got, and do try, use that Q&A thing. I think works a little better than the chat. And just about anything in here I'd like to talk more about, so.
So Suzanne, as the questions are coming in, I would like to ask you to say that you mentioned at the beginning about Indigenous disease ideology. And you mentioned sort of a natural, like one source of disease is natural, the other is supernatural or spiritual, and then sort of a third category, sort of a post-colonial category of white people's disease. Mm-hmm. Where does COVID fit in that framework?
That's a great question. I have not heard folks specifically reference it. I would hazard a guess that it would be considered a settler colonial importation from sort of the world out there, because although, right, I mean, even those things that come with sort of settler colonial diseases, they always have a spiritual element to them, right? So like there was a really interesting study with the Winnebago about diabetes prevention, and they were interviewing folks about how do you understand diabetes and what do you understand it to be? And a lot of the respondents had said, well, you know, it's this insulin thing and blood sugar levels, but it comes from grief, and it's inspired by sadness, and it comes from spiritual trauma, and spiritual trauma makes you much more vulnerable to diabetes. And of course, this is true. This is really true, right? There's so much to that. But so even these things that are seen as sort of imported settler colonial disease, always has that kind of spiritual component to it. And it's the restoration of relationships that tends to address it. If you had the opportunity, as a question, if you had the opportunity to be part of the Indigenous community right now with COVID-19 running rampant, would you do so? I think I would, if I had, I would absolutely live within community and participate in that community, and I would honor their requests to maintain social distancing and isolation. So I think right now being part of a community is a lot like being part of a community for us right now, which is you stay in your house and you're interacting through online, and you're interacting through other ways that you can exhibit support. So, and then of course some folks are essential workers and they're working away. So if, I think definitely they are at higher risk often because of those secondary complications and illnesses that they carry. But no, I think it's all the more important to be part of those communities while respecting their request for social distancing. Are most reservations still closed, or additional reservations closing down? That's really varying day to day. Like just even this morning, I was trying to catch up on what's going on with different communities. So some are, as you know, the Puyallup and some are slowly opening up. They're wanting to get those casinos open, so they're doing that very gradually, especially communities that really depend on casinos. But others are remaining, as you see on the Washington coast, those that are able to close down or closing down. My 236 class, we just had a really great conversation with a friend who does work up in the Northern Territories with the Dene. And he was talking about how since they've closed down, a lot of folks are returning to traditional subsistence, and it's actually been kind of a resurgence of culture because they're not going out to go shopping, so they're going hunting. Becca, when did you first become interested in studying the lives and experiences of Indigenous communities? College. I got started in college. I had great history teachers. So and I have some degree of Native heritage through my dad, and so I knew that was back there, several generations removed, but there. So I always felt kind of an interest and obligation to want to learn more about that. But yeah, I had some excellent history teachers at Willamette University who taught me about Native American history, and that I think really got me seriously interested. For the tribes who have reopened their casinos, do you suspect it's out of necessity to provide rather than things have gotten safer, slower? I think they're definitely motivated by economic concerns, of course, right? I mean, they need to fund their hospitals. So they're like legit economic concerns. And I think they're very much like all of us. We're trying to find a way to survive in a way that's going to keep us from going out of business and also be safe. I'm not a casino goer myself, so I haven't had to make that decision. But yeah, no, And I think, you know, and again, it depends on where you're at and what the rates are in your local area and how they're doing it. I know they're trying really, really hard to make it as safe as they can. Do you know if the federal government has given essential internet or hotspots to Indigenous communities' education and work? Interesting. Actually, just learned about this. The CARES Act funds, some tribal communities have been able to, they just were recently learned they could use those, at least some of them. I'm not sure if it varies by community or state, but at least some of them are able to use the CARES Fund Act for Wi-Fi, upgrading their Wi-Fi service and cellular service. So some of using, I know some others are using CARES Act fund to build small houses, little mini micro houses for quarantining as needed. And so some uses like that. So some CARES Fund Act has been put toward Wi-Fi. Do you know if the federal government has given? Yes, we already did that. How do you deal with the moral dilemmas around being a white person who studies Native peoples? Oh my gosh, that's a really big question. Yes, this is a huge thing, right? And so a lot of reading, a lot of great thinking about how to do work when you're not working with the community that you're a part of. So this is definitely, so I teach religious diversity in North America. Everything I teach, I'm not a part of. It's a group I'm not a part of. So in everything I do, I have to think about how do I, and generally speaking, I'm almost always teaching about minoritized communities who have experienced systematic oppression or suppression in some way. So it's always such a question, right? And it's not what I can answer well in a minute, but it has to do with how you approach the community, seeing yourself as more of a servant and less than an expert. For me, it's like, what can I do to get the word out to improve their situation? So opportunity like this, if I can call the attention of a whole bunch of folks to say, these communities need us to advocate on their behalf. They need us to write to our Congress and our senators and say they need real funding and they need real support and we need to fund the health service. Like, let's all do that, right? So anything I can do to uplift their needs and point toward those voices, anything I can do to bring Native voices into the room, whether it's in text or film or guest speakers or getting students out to a community, anything I can do to bring those voices and uplift those voices, that's my whole mission in life. Like that's why I'm there. So it's really complex and it's definitely, but I see myself as being just, I'm here to be of service if I can be in any way. If I can use this thing to be at all of use, then that's what I want to do. Okay, don't want to go over time. Do you know if the government has provided more support for healthcare during COVID? I don't think so. I don't know that funding has gone up during COVID. I have not heard that. I know that they're requesting funding. I'm sure there's been some kind of, the CARES Act and emergency funding to some degree. But I think as all of us are finding, funding is slow and it's held up in bureaucratic conversations. If Congress is not in session, and if Senate won't vote on things, then funds are not coming. So I think, I imagine as part of COVID relief in general, there's been some funding, but it does not appear to have been sufficient from anything that I'm seeing. I think it's been really problematic. And so again, if I can return to that first question, after the land acknowledgement, what do we do? Well, one of the things we can do is call and write our leaders and say, we really need to actually honor our treaty obligations to tribal people and fund healthcare for real, and in a way that it's not utterly shameful.
Oh, wow. Thank you so much, Suzanne. Sorry I popped in and out there. I inadvertently popped in earlier than I should, but thanks for an incredibly engaging and important lecture today. It's just really been wonderful. And I'm sure I speak for others when I say that underscoring the impact of COVID-19 on people of color in the US generally, but the US Native American communities in particular, has added a really important dimension to this sequence of lectures, because we know how devastating the impact has been, especially on this community. And I have, and I'm sure others have learned so much or we sort of realized once again, Carminia's talk did a similar kind of review of worldviews, how much we have to learn from Native American communities and Indigenous traditions generally. So thank you so much. We're delighted you could join us. Now, unfortunately, we have these sort of abrupt endings and announcements for next week. So it's my turn to let everybody know that next week, in some ways, it's very connected to today's lecture, because what Suzanne has presented has raised some really interesting ethical issues about how choices are made at the governmental level in terms of different constituencies in the United States. So we move next week to our first lecture dealing with ethical questions that are raised by the COVID-19 pandemic. And we will be welcoming Dr. Serja Hay, who's Associate Professor of Philosophy and Director of the Wild Hope Center, and Dr. Paul Menzel, Professor Emeritus of Philosophy, for their lecture called Ethical Decision Making During a Pandemic. And it looks really exciting. We'll be asking some very interesting questions. And we look forward to everybody joining us next week. But for now, Suzanne, thank you for a wonderful lecture.
Thanks for having me.
Yeah, thank
Teresa,
you so much.
good night. Thank you very much. Bye-bye.
Good night, everyone.